Bismillahirrahmanirrahim. Today's lecture is on syndromic ichthyosis. So we will straight away start with the different type of syndromic ichthyosis. The first one, where the first group includes X-linked syndromes, which are concerning distal cholesterol biosynthesis. So there are two features of these syndromes, that is, all of them are X-linked ichthyosis, and there is some defect in distal cholesterol biosynthesis. The first of the syndromes is Conradi-Huntermann-Happel syndrome, which is abbreviated as CHHS. It is an extremely rare X-linked dominant skin disorder that usually affect only females, as it is lethal in males. That's true in all the X-linked dominant disorders. Clinical hallmark of Conradi-Huntermann-Happel syndrome are the mosaic presentation of linear ichthyoses, chondrodysplasia punctata, asymmetrical shortened limbs, unilateral and sometimes sectorial cataract, and short stature. Due to mutation in genes for MOPAML binding protein that functions in the late steps of cholesterol biosynthesis. Within the first year, a generalized linear or swirling pattern of erythroderma and scaling that follows lines of Blaschko. Palmoplantar hyperkeratosis and nail dystrophy occur. Recurrent infections, especially the flexures, can be troublesome. Scalp and eyebrow hairs are sparse and lusterless. So most of the ichthyotic disorders, they affect the hairs. The main feature of ichthyosis in CHHS is linear ichthyosis in Blaschkoid distribution. And in addition to that, the other systems which are involved include the eyes, resulting in cataract and asymmetrically shortened limbs. Treatment. Emollients are helpful in controlling ichthyosis, and antimicrobial therapy may be needed for skin infections in infancy. Continued orthopedic surveillance and appropriate procedures may be indicated for the skeletal abnormalities. Cataract usually do not affect the vision because they are at the peripheral portion of the lens. The other syndrome is congenital hemidysplasia ichthyosiform nevus limb defect, which is abbreviated as child syndrome. This syndrome again is a very rare X-linked dominant disorder seen in female and lethal in male. And again it is due to a distal cholesterol biosynthesis deficiency. Clinical hallmark of child syndrome is due to mutation of NSDHL gene. This nevus shows hyperkeratosis, which has typically yellow wax-like scaling. Associated ipsilateral hypoplasia or aplasia involves the limb and other skeletal structures, as well as internal organs like lung, heart, and kidney. So the hypoplasia and aplasia is not asymmetrical like in CHHS, but it is unilateral, ipsilateral, and involves the skeleton, as well as it involves the underlying vasculature like lung, heart, and kidney. Then the third syndrome which comes in this list is ichthyosis follicularis-atrichia photophobia syndrome, which is abbreviated as IFAP. IFAP is a X-linked recessive trait that featuring ichthyosis follicularis, atrichia, photophobia, and severe retardation of growth and psychomotor development. Since it is, as the name signifies, the ichthyoses is limited to the hair follicles, so the follicular involvement is very prominent, especially over the knees. And the syndrome also contains atrichia, so it is characterized by non-cicatricial complete body alopecia along with atopic eczema. There is moderate response to low dose acitretin. Emollients are helpful, and intensive lubrication of ocular surfaces is important to reduce the photophobia. The fourth syndrome here is IFAP, which is again ichthyosis follicularis with alopecia and photophobia. So these features are also seen in ichthyosis follicularis-atrichia photophobia syndrome. But but this syndrome is different from the previous one because it does not have any psychomotor or growth retardation. It presents as non-cicatricial alopecia of body and scalp hairs and photophobia due to punctate keratitis and corneal erosions. And there will be keratotic papules because of ichthyosis follicularis that would be prominent on knees, elbow, and fingers. Generalized xerosis and cheilitis may also be seen, and pruritus is common. So, to summarize the disorders which are characterized by X-linked recessive inheritance and have a defect of distal cholesterol biosynthesis, is that in all these disorders, in addition to the different type of ichthyosis, there will be some skeletal defect and eye involvement. Ichthyosis is a little different in these syndromes. For example, in Conradi-Hunderman-Happel syndrome, the ichthyosis is linear in the Blaschkoid fashion, while in child syndrome, the ichthyosis is characterized by typical yellow waxy-like scaling. Then there are two syndromes in which there is follicular ichthyosis. That is IFAP syndrome, in which there is full-fledged growth retardation along with the photophobia and hypoplasia of limb, and the other one is IFAP, simple IFAP syndrome that is not characterized by growth retardation and psychomotor developmental delays. The second subgroup of syndromes that is characterized by ichthyosis are those syndromes in which there is no simple ichthyosis, but rather there is exfoliation as well. So these are called as exfoliative disorders of cornification. Among these disorders, the first is the most common and important disorder, which is called as the Comel-Netherton syndrome, or simply as Netherton syndrome. It is considered as the most common of the multi-system ichthyosiform syndromes and comprises of an ichthyosiform dermatitis, which is characterized by episodic peeling, variable degree of erythroderma, hair shaft defect, and atopic features. It is inherited as autosomal recessive. The gene mutation is of the serine protease inhibitor Casl type 5, which is called as the SPINK5 gene. The main characteristic is of generalized erythroderma that is of variable intensity, and it starts shortly after birth. The characteristic ichthyosis in Netherton syndrome is the ichthyosis linearis circumflexa, which is characterized by serpiginous lesions with characteristically polycyclic migratory annular scales with double borders. You can see the double border of the scales here. So they are migratory, They are polycyclic. The lesions are annular with double borders of the scale. This is Ichthyosis linearis circumflexa. There is prominent involvement of trunk as well as the limbs. In severe CNS, involvement of in severe Comel-Netherton syndrome, a fluctuating erythroderma persists, which may be triggered by intercurrent illness, and rarely pustular lesions are superimposed. And there is gradual improvement in most patients. Now, something more about ichthyoses linear circumflexa. I have already described that what are the characteristic features of this kind of ichthyosis. That is migratory annular polycyclic with double layer of scales. This condition leaves no scarring or pigmentary changes. Inheritance is autosomal recessive. Patients are born erythrodermic. 1/3 can have fatal complications. And the hair shaft defect is trichorexis invaginata. And may clear completely in summertime. Trichorexis invaginata is also called as the bamboo hair shaft defect. In childhood, scalp, eyebrow, eyelashes, and even body hairs remain sparse, slow growing, lusterless, and brittle. Hair growth, however, improves with age, but it may be unruly, short, and spiky. What is seen mainly in Trichorexis invaginata is the invagination of hair shaft into one and each other, and some ball and socket defect. Atopic features are also seen in Netherton syndrome, and the patients have personal or family history of atopy, especially hay fever or asthma. The question as to whether they may have atopic eczema is controversial. Pruritus, flexural accentuation, and period of remission and raised IgE are all suggestive of atopic features. The skin lesions are not clinically eczematous, rather they are rather ichthyotic, and histopathological features are not consistent, and the patients do not respond to the normal therapy of eczema. Histopathology is slight parakeratosis associated with psoriasiform hyperplasia and mild chronic inflammatory infiltrate, so no specific feature of this syndrome. Diagnosis. The triad of congenital erythroderma, poor hair growth, and failure to thrive in infancy supports the diagnosis of ichthyosis linear circumflexa. In milder cases without a family history, diagnosis is delayed until specific hair shaft defect is identified, that is of Trichorexis invaginata. Total IgE levels peak often at very high values in early childhood and then may fall towards the normal range. Treatment. In the neonatal period, intensive medical and nursing and nutritional care must be available to manage the erythroderma and its complications. Topical corticosteroids are ineffective, but intermittent mild topical corticosteroid therapy lessens the facial erythema. Regular emollients are helpful. Keratolytics are poorly tolerated. Significant improvement in cutaneous feature with topical tacrolimus 0.1%. The peculiar feature of Netherton syndrome is deterioration induced by systemic retinoid therapy, which is usually beneficial in other kind of erythrodermic ichthyosis. Why? Because retinoids are known to aggravate the atopic eczema. Psoralen and UVA therapy, PUVA, and ultraviolet B therapy have proved variable results. Methotrexate and cyclosporin are ineffective in this case. So the main management of patients with Netherton syndrome is by emollients and topical tacrolimus with little bit of keratolytics. Then the second syndrome, which is characterized by exfoliation or exfoliative ichthysis, is peeling skin syndrome type A. It is characterized by generalized and non-inflammatory skin shedding, which is called as keratolysis exfoliativa congenita. There is a single recessive missense mutation in CHST8. Usually start at the age of 3 and 6 and characterized by generalized skin peeling with areas of hyperpigmentation without skin blistering and erythema. And there is no other associated disorder. So just characterized by skin peeling that start between 3 to 6 years of age. Then the third variety is inflammatory skin peeling. The previous one was non-inflammatory skin peeling. Now this is the inflammatory peeling skin disease. Refers to PSS type B and is characterized by ichthyosiform erythroderma that is characterized by a lifelong patchy peeling of the skin and accompanied pruritus. Inheritance is autosomal recessive and is because of loss of function of or mutation in CDSN gene that is encoding corneodesmosins. This disease presents at birth or few days later. Infants develop ichthyosiform erythroderma with spontaneous patchy peeling. It is aggravated by low humidity and temperature changes. The disease persists throughout the life and is often accompanied by significant atopic manifestations, but there is no hair shaft defect. There is no effective treatment. Emollients with dexpanthenol and antiseptics or use of thermal water sprays can be tried. Now the fourth peeling syndrome. The first one was Netherton, the other one was non-inflammatory peeling, then inflammatory peeling, but both non-inflammatory and inflammatory peeling were involving the whole skin, and the fourth syndrome is only involving the acral surfaces. So it is called as the acral peeling skin syndrome, which is sometimes confused with epidermolysis bullosa simplex of localized type, and it is recently reclassified as a type of epidermolysis bullosa. This is autosomal recessive disorder, and there is a missense mutation in TGM5 encoding transglutaminase 5. The disease is characterized by superficial painless peeling of the skin, predominantly on the dorsal aspects of hand and feet. Attempts to identify a specific fungal or bacterial growth is usually not successful. Now the third syndromes, which are category of syndromes that are associated with ichthysis, are called as neuroichthyotic syndrome, because in these syndromes there are CNS findings along with ichthysis. Among this category, the first syndrome is the Refsum syndrome. Refsum syndrome is inherited as autosomal recessive disorder, and it is caused by impaired oxidation of phytanic acid, a 20-carbon branch fatty acid. This results in accumulation of phytanic acid, which interferes with membrane structures and functions. The mutation of PAHX gene is located at chromosome 10p13. Clinical features of Refsum syndrome. In skin, it is characterized by ichthysis. In CNS, it is characterized by ataxia and peripheral neuropathy. Eyes, retinitis pigmentosa, salt and pepper. Ears, deafness. Cardiac arrhythmia, block, and congenital heart failure. musculoskeletal wasting and skeletal abnormalities. So Refsum syndrome typically affects the eyes, ear, CNS, heart, and musculoskeletal. The treatment involves lifelong exclusion of diets that contain chlorophylls. The major dietary exclusion is the green leafy vegetables and animal fat that contain phytols. Rapid weight loss should be avoided as it mobilizes the tissue phytanic acid and can lead to acute clinical manifestations. Nowadays, a new therapy is lipid apheresis, which is an extracorporeal elimination of lipoprotein phytanic acid complex and is used as an initial treatment followed by a phytanic acid poor diet. High carbohydrate diet also helps in improvement of skin and neurological features. The second syndrome, which comes in the category of neuroichthyosic syndromes, is the Sjögren-Larsson syndrome. There is a microsomal fatty aldehyde dehydrogenase deficiency. FALDH catalyzes the oxidation of many different fatty aldehydes and fatty acids into fatty acids. Its deficiency results in accumulation of fatty aldehydes and fatty alcohols in various tissues, among which LTB4 is the reason of pruritus. A velvety orange or brown lichenification, sometimes topped with verrucous hyperkeratosis, is most obvious in and around the flexures, neck, and periumbilical fold. So the distribution is quite typical. Then skin has a yellow-brown color and appears wrinkled. Severe persistent pruritus is a notable feature. Scratch marks and dermographism is often seen on the trunk. There are upper motor neuron signs, that is a non-progressive spastic paraparesis in leg and rarely in arm. Development of speech is delayed and seizures may be a rare complication. There is mild to moderate learning difficulties. Ocular signs are reported in 1980 and consist of glistening dots on fovea and parafoveal areas of retina, which develop during childhood and which do not seem to interfere with the vision. So although the signs are of atypical retinitis pigmentosa like glistening dots, the patient will not get blind as in Refsum syndrome. So the patient is diagnosed by cutaneous and retinal features along with the spastic paraparesis, mainly in the limbs, and extreme degree of pruritus. The pruritus is unusual in this case, and very few ichthyosic syndromes is characterized by such a high degree or high intensity of pruritus. So during examination of neuroichthyosic syndrome, always keep in mind that whenever you see a child with ichthyosis, you will always ask the mother or the child to walk, because ataxia, hemiparesis, or any spastic paraparesis will be demonstrated in this way. For all ichthyosic syndromes, it is also must that you should check the vision as well as hearing. Treatment. Dietary approach with supplementation of medium chain fatty acids have not been successful so far. Inhibition of LTB4 synthesis by Xylitol improves pruritus in some patients, but not ichthyosis. Xylitol is an important treatment modality. If you don't remember the name, just remember that it inhibits the synthesis of LTB4. Then retinoid therapy, which is acitretin, is proved effective in relieving scaling and disabling keratotic lichenification. So because of spastic paraparesis, the patient requires physiotherapy and skill learning in early childhood. Bezafibrate, a lipid-lowering agent, was shown to induce FALDH activity in fibroblast in patients with residual enzyme activity. The fourth syndrome in this category is the KIT syndrome. KIT syndrome is characterized by the features of keratitis, ichthyosis, and deafness. The ichthyoses is Hystrix-like ichthyosis, and the mutation is in gap junction proteins, which are called as connexins. Most patients have extensive scarring alopecia of the scalp with loss of eyebrows, eyelashes, and body hair resulting from follicular hyperkeratosis and atrophy. A reticulate palmoplantar keratoderma resembling a grained leather is characteristic feature. And progressive nail dystrophy and shedding may occur. Congenital severe sensory neural deafness is evident during infancy. Progressive corneal vascularization occur in early childhood after a febrile illness and leads to photophobia and blindness in adolescents in 75% of the patients. So keratitis and lead to photophobia and blindness. Deafness is sensorineural deafness, and ichthyosis is mainly follicular hyperkeratosis that leads to loss of hairs as well. Management. Early and frequent audiological and ophthalmological assessments of patients with KIT syndrome is necessary. Surgical procedures like corneal transplant is used to treat the advanced keratitis, but this has not been very successful. Cleansing, debridement, dressing, excision of hyperplastic lesion, and grafting may sometimes become necessary. Systemic retinoids like acitretin are helpful in controlling the disease, but isotretinoin may exacerbate the corneal neovascularization. A recent report treatment with alitretinoin resulting in marked improvement. Then a neutral lipid storage disease, which is Chanarin-Dorfman syndrome. This, like other lipid storage disease, is characterized by myopathy, ichthyosis, and lipid vacuoles. There is impaired degradation of triacylglycerol derivative diacylglycerol. Dietary modulation of fats acid in controlling the disease. Lipid vacuoles are seen in granulocytes and monocytes, but not in lymphocytes. These are the lipid granules which are seen in the granulocytes. The pattern of skin disease thereafter resembles mild to moderate non-bullous ichthyosiform erythroderma with fine white scales on an erythematous background. Pruritus is again troublesome and hypohidrosis may occur. Muscle involvement range from asymptomatic or subclinical myopathy with elevated muscle enzymes and most patients with marked proximal myopathy. Hepatomegaly, abnormal liver function, and fatty infiltration of liver is common. So liver biopsy is a sensitive investigation to detect the degree of involvement. Treated by emollients, retinoid therapy, either low dose, continuous or intermittent course, and dietary manipulation to reduce intake of long chain fatty acid and increase medium chain fatty acid, which appears to be beneficial. So this lipid storage disease or the Chanarin-Dorfman syndrome is characterized by myopathy and ichthyosis with hepatomegaly and abnormal liver enzymes. Then TE or IBIDS syndrome. The acronym IBID describes ichthyoses, brittle hairs, impaired intelligence, decreased fertility, and short stature. If this syndrome is seen with photosensitivity, then it is also called as the PIBIDS. There is a reduced level of hair sulfur and sulfur-containing amino acids, cysteine, methionine, and proline. That is the hallmark of trichothiodystrophy, but circulating amino acid levels are normal. So the management is mainly by emollients. Effect of retinoids on ichthysis have been disappointing. Strict sun avoidance is required in PIBIDS, and protective measures like sunscreens are used. Advice to avoid physical hair treatment is helpful in reducing further hair damage. Now we are going to discuss a few disorders that is characterized by ichthysis later in the life. So ichthysis can be acquired with many different malignancies like in Hodgkin's disease, in non-Hodgkin lymphoma, in mycosis fungoides, in multiple myelomas, in carcinomas of breast, lung, cervix, and liver, leiomyosarcomas, Kaposi sarcoma, and in AIDS with or without any demonstrable malignancy. So these all ichthyosis are not present since birth or early childhood, but develop once the patient develops the malignancy or age. Ichthyosis is also acquired in several non-malignant diseases. Like ichthyosis is seen in several malnutrition syndromes and malabsorption disorders with essential fatty acid deficiencies, in pancreatic insufficiency, in renal failure with or without secondary hyperparathyroidism, in hypopituitarism, in hypothyroidism, in diabetes, in connective tissue diseases like SLE and dermatomyositis, in sarcoidosis, in leprosy, lepromatous leprosy, and following a bone marrow transplant. So there is a long list of disorders which are characterized by acquired ichthyosis. There are several drugs which are characterized, which causes ichthyosis. The most important of them are the cholesterol-lowering drugs, triparanol and nicotinic acids, HMG-CoA inhibitors, butyrophenones, phenothiazine, cimetidine, allopurinol, hydroxyurea, and clofazimine. So clofazimine is given in lepromatous leprosy, and it induces ichthyosis, and ichthyosis is already induced by the disease itself, the lepromatous leprosy. So the lepromatous leprosy patients have ichthyosis due to two causes, due to the disease and due to the clofazimine. Then there is a disorder which is to be discussed here, and it is called as the Pityriasis rotunda. This is characterized by persistent, sharply defined circular patches of ichthyosiform scaling with no inflammatory change. This disorder is relatively common in Far East, especially in Japan. Tuberculosis and malnutrition coexist in up to 50% of patients. It may rarely be acquired cutaneous marker of malignancy. This is how Pityriasis rotunda looks like. The typical lesions are sharply circular hyperpigmented patches of dry ichthyosiform skin, usually 2 to 3 centimeter, but can be as big as 14 centimeter. Lesion numbers from 4 to 200. They are rarely itchy. And common sites are buttock, thigh, abdomen, back, and upper arms, hidden sites. So most often develop between ages of 20 to 45 years. The histological changes are those of Ichthyosis vulgaris with compact orthokeratosis and reduced granular layer and pigmentary incontinence, which is mainly the pigmentary incontinence is cause of hyperpigmentation. Emollients like urea compound and topical keratolytics may help. Topical tretinoin cream and systemic retinoids in more extensive disease can be useful, but topical steroid and antifungals are not. Where malnutrition, infection, or malignancy is clearly an underlying cause, appropriate therapy is definitely required. So this ends with our topic of ichthyosis. So from next week, I'll take up the topic of keratodermas. So thank you for today and goodbye.